Welcome to This Explainer. Today, we're diving into a truly game-changing concept in critical care, the ABCDEF bundle. You can think of this as our ultimate framework. It's a precise, totally evidence-based roadmap derived directly from clinical standards, and its whole purpose is to guide critically ill patients away from immobility and straight toward active recovery. So if you've ever wondered how we safely wake patients up and actually get them moving again, you are absolutely in the right place. Let's get started.
Here's how we're breaking it all down today. First, we'll be decoding the bundle itself. Then, we'll look at safety and baseline assessments, executing early mobility, and progressing to full ambulation. After that, we'll talk about engaging the family in recovery, and finally, how we track outcomes and quality. All right, let's jump straight into Section 1, decoding the ABCDEF bundle, which is the absolute foundation of recovery. In an environment as complex as the intensive care unit, we really need a structured, memorable anchor to keep everything on track. So what exactly does ABCDEF stand for? Well, it's pretty straightforward. It stands for Assess, Prevent, and Manage Pain, both spontaneous awakening and breathing trials, choice of analgesia and sedation, delirium assessment, early mobility and exercise, and finally, family engagement. For today's explainer, we're going to focus heavily on the E and the F. But remember, those first four letters, they're the absolute crucial safety gateways we have to pass through before we can even begin to think about moving a patient.
Moving right along to Section 2, Safety and Baseline Assessments, or what I like to call the pre-flight checklist.
Okay, let's dive into this. Before we even consider moving a critically ill patient, we have to run through some really strict pre-flight safety checks. These are basically our ultimate green lights. We validate their baseline vital signs, and we assess the depth of their sedation using tools like the RASS. That's the Richmond Agitation Sedation Scale. We're also confirming all oxygen and ventilator settings, making double sure every single drain, line, and catheter is secure, and verifying that the mean arterial pressure, or MAP, is at least 65 millimeters of mercury without having to escalate vasopressors. Honestly, this step is completely non-negotiable.
Building directly on those safety protocols, we also rely heavily on validated stop criteria. Look, pushing a patient toward recovery is absolutely critical, but safety and hemodynamic stability always come first. If that heart rate spikes over 130 or drops below 40 beats per minute, we stop. If the systolic blood pressure shoots above 180 or tanks below 90, we stop. And if oxygen saturation dips below 88%, we terminate this session immediately. These thresholds are there for a reason. They protect our patients from dangerous physiological overload.
Section 3, Executing Early Mobility. This is where we master the E.
Now, what's really interesting about this slide is how we progress from passive to active care. Once our patient is stable and cleared, we shift right into the E in our bundle. For our sedated or unconscious patients, we start with passive range of motion, or a PROM. We do 3 slow, controlled, pain-free movements per joint at least twice a day. But as the patient wakes up and gets stronger, we don't just stay there. We progress to active range of motion, or AROM, where the patient actually leads the movement. It's a massive, vital transition to prevent contractures and get that circulation going. From there, we literally start to rise. The upright positioning progression is heavily structured. First up, we elevate the head of the bed from 30 up to 80 degrees. Then, we advance to sitting right at the edge of the bed. You'll often hear this called dangling, while we closely watch their truncal stability and balance. Now, for patients dealing with severe deconditioning or maybe a neurological impairment, we might bring in a tilt table or a standing frame. Throughout this entire physical rise, we are constantly on the lookout for orthostatic hypotension. We have to make sure their blood pressure doesn't just bottom out as they get upright. Why do we do all of this? Well, we're fighting a massive enemy in critical care: ICU-acquired weakness. We keep a close eye on this using the Medical Research Council, or MRC, sum score. If a patient scores less than 48 out of 60, that indicates severe weakness. To fight back against this really profound disuse atrophy, our early mobility targets high-risk muscle groups. Think hip flexors, knee extensors, ankle dorsiflexors. Because if we don't actively target these muscles right away, the atrophy can severely delay their long-term recovery. All right, Section 4, Progressing to Full Ambulation. This brings us to what is easily the most dynamic phase of recovery, taking those very first steps. But how do we actually know they're ready? We don't just guess. We rely on some very specific clinical criteria. A patient has to be able to follow two-step commands, which proves cognitive readiness. They need to be able to bear weight with 2 or fewer assisting staff. Their RAS score needs to be -1 or higher, meaning they are alert enough to participate. And finally, they have to demonstrate absolute hemodynamic stability during a pre-ambulation standing trial. Once they've got the green light, we initiate a highly structured ambulation plan. We don't just say, hey, walk as far as you can. We start small, 2 to 5 meters right there in the room. Next, we progress to 10 to 20 meters out in the corridor. Then we methodically bump up the distance by 10 to 20 meters per session. And throughout all of this, we are meticulously tracking their fatigue using the modified Borg scale to gauge their perceived exertion. We want to challenge them, for sure, but we absolutely must avoid physiological overload.
Now, for patients with severe weakness or complex neurological conditions, the ICU literally transforms into a high-tech innovation hub. It's amazing. We bring in technology-assisted modalities like in-bed cycle ergometers and functional electrical stimulation. We even use robotic-assisted gait training systems like the Locomat or ExoGT and virtual reality rehab for cognitive and balance training. It is absolutely incredible how these tools can kickstart motor reactivation for folks who just can't participate in conventional therapy yet.
Section 5. Engaging family in recovery. Let's talk about the F factor. It's time we humanize this clinical data a bit. Think about this directive for a second. Acknowledge and address psychological barriers to rehabilitation engagement, including fear of pain, fear of falling, post-traumatic anxiety, low self-efficacy, and depression. Addressing these unseen wounds like PTSD and deep-seated fear is just as important as staring at a heart rate monitor. If a patient is completely terrified of falling, their physical recovery will just stall out. We have to address the existential and emotional impact of what they've been through with genuine empathy.
And this is exactly why family integration is such a game changer. We empower families using the Teach Back methodology. Basically, we educate the carers on the patient's reactivation plan, and then we ask them to teach it back to us to make sure they've got it. By training family members to safely help with simple range of motion exercises and just generally encouraging activity during visiting hours, we extend therapy way beyond our formal sessions. It's a vital strategy for tackling post-intensive care syndrome, or PICS, and it really sets the patient up for success when they finally head home. And finally, Section 6, tracking outcomes and quality. So how do we prove this whole framework actually works? 72 hours. That is the absolute maximum time allowed to pass before we must formally review and set new, measurable, smart benchmarks for our patient's functional progression. Whether it's the amount of time they spend sitting out of bed or the actual meters they ambulated, goals have to be constantly updated to match the patient's trajectory. We never, ever let the therapy plan stagnate.
And this brilliantly illustrates how we capture that functional recovery over time. We use validated tools like the Berthel Index, the Functional Independence Measure, and the 6-minute walk test. Tracking these outcome measures objectively informs everything we do, from daily rounds to community rehab referrals and discharge planning. It gives us a crystal-clear, data-driven picture of the patient's actual journey back to independence.
Which brings us to our final, and probably most important point. We've decoded the bundles together, we've walked through those rigorous safety checks, and we've seen firsthand the power of early mobility and family engagement. But honestly, all of this information only matters if you actually apply it. So my question to you is, how will you implement the ABCDEF bundle in your unit today to transform patient recovery? Take these insights, go reevaluate your early mobility protocols, and start actively reshaping your clinical practice. Thank you so much for joining me for this explainer, and I really hope you leave today fired up to put this framework into action.